Throughout the assessment, observe the child's verbal and nonverbal behaviors. Determine level of consciousness and orientation by observing and talking to the child. Obtain temperature, heart rate, respirations, and blood pressure. For an infant, count respirations first before disturbing the infant, take the pulse next, and measure temperature last. Inform the child if developmentally appropriate and family of vital signs. Measure the child's temperature. Rectal temperatures are more invasive and are contraindicated in a child who has had recent rectal surgery, diarrhea, or anorectal lesions, or who is receiving chemotherapy. Oral temperatures can be taken when the child is developmentally able to cooperate. However, limitations such as recent oral intake, an altered level of consciousness, or a recent oral surgery may exist. Ear, tympanic thermometers with an appropriate size oral probe and in the proper position provide an accurate measurement in seconds, and the procedure is usually tolerated. Measure the child's pulse rate. Auscultate the apical pulse and count for 1 full minute. Assess radial and pedal pulses and compare bilaterally. Count the respiratory rate by auscultation or by counting chest rise and fall. Count respirations for 1 full minute. If the child is agitated or crying, defer this step to later in the examination. Measure blood pressure with appropriate size equipment. Ensure that the bladder cuff width is at least 40% of the length of the arm between the elbow and the axilla. The bladder cuff length should cover 80 to 100% of the upper arm circumference. If the correct size cuff is not available, use an oversized cuff rather than an undersized cuff, or use another site that more appropriately fits the cuff size. Assess speech and determine whether it is developmentally appropriate and understandable for the child's age. If uncertain whether the child understands a question when asked, rephrase the question in simpler language. Use developmentally appropriate conversation to measure orientation to person, place, and time. If a child is not old enough to give information about person, place, and time, document that the child's behavior appears to be appropriate for his or her developmental level. For example, recognizes family members, demonstrates wariness of strangers. If the child is disoriented in any way, include subjective or objective data in the documentation. Elicit input from the child's family regarding his or her normal behavior and changes that are noticed. If the child is unable to respond to questions of orientation, offer developmentally appropriate commands. For example, squeeze my fingers or move your toes. Use the Glasgow Coma Scale to assess level of consciousness as indicated. Assess posture and position. Observe alignment of shoulders and hips while the child stands or sits. Observe whether the child has a slumped, erect, or bent posture. If the child is unable to sit or stand alone, note the child's muscle tone and posture when lying and being held. Assess body movements. Observe whether body movements are symmetric and purposeful. Observe whether tremors in the extremities are present. Observe whether movements are coordinated or uncoordinated as developmentally appropriate. Observe hygiene and grooming for cleanliness, odors, and condition of hair, nails, teeth, and feet. Observe the color, distribution, quantity, thickness, texture, and lubrication of hair. Observe for bald or thinning spots. Inspect for ticks, tinea, ringworm, or lesions in the scalp. Inspect the condition and shape of nails. Assess for the presence or absence of body odor. Assess the eyes. Inspect position of eyes, color, condition of conjunctiva, and movement. Assess for exudate, abnormal tearing, and redness or swelling. Assess the child's vision using developmentally appropriate assessment tools. Test visual acuity using the Snellen letter chart for a child of preschool age or older. If the child is unable to identify letters, use a tumbling E-chart or an Allen card with common symbols that a non-reading child can identify. Inspect the pupils for size, shape, and equality. Test pupillary reflexes. If possible, darken the room for this test. As the child looks straight ahead, move a pen light from the side of the child's face and direct the light on the pupil. Observe the pupillary response of both eyes, noting briskness and equality of reflex. Assess for extraocular movement in all 6 cardinal positions. If the child is too young to follow directions, observe while moving a favorite toy or a family member's face in each of the 6 cardinal directions. Assess hearing. Observe the child's response to auditory stimuli and the presence of a hearing aid. If the child has a hearing deficit, inspect the child's ears. If hearing loss is suspected, refer for further evaluation. Inspect the nose externally for shape, skin color, alignment, and presence of deformity or inflammation. Document the color of mucosa, any lesions, discharge, swelling, or presence of bleeding. If the child has a nasogastric or nasointestinal tube, inspect the nares for excoriation or inflammation. Stabilize the tube as needed. Assess the mouth. Use a tongue blade to depress the tongue lightly. Illuminate the oral cavity with a pen light. Inspect the oral mucosa, tongue, teeth, and gums for dehydration, discoloration, and obvious lesions. Assess oral hygiene and observe for exudate on the tongue or palate, caries on the teeth, or trauma to the gums or teeth. Ask if the child or family has observed any changes in the skin, such as pruritus, oozing, bleeding, change in the appearance of a mole, bump, or nodule, or a change in sensation, such as itchiness, tenderness, or pain. Petechiae. Inspect skin surfaces. Visually scan the entire body, looking for scars, bruising, patterned injuries, or abrasions that may be signs of maltreatment or self-harm. Look for any patches or areas of skin color variation. Carefully inspect the color of the face, conjunctiva, sclera, and nail beds. Use fingertips to palpate skin surfaces to feel moisture of intact skin. Palpate skin surfaces lightly with fingertips to detect texture of skin surface. Note whether the skin is smooth or rough, thick or thin, tight or supple, and whether localized areas of hardness or lesions are present. Using the dorsum, back of the hand, palpate for temperature of skin surfaces. Compare bilateral body parts. Compare upper and lower body parts. Observe for any distinct temperature differences and localized areas of warmth. Assess skin turgor by gently pinching a fold of skin on the torso or forearm. Release the skin, noting the ease and speed with which the skin returns to its place. Assess the condition of the skin for pressure injuries, paying attention to bony prominences, for example, sacrum, greater trochanter, heels, occipital area, clavicles. If areas of redness are observed, determine if the redness is blanchable. Assess for skin lesions. If any lesion is detected, don clean gloves. With adequate lighting, inspect the lesion for color, location, texture, size, shape, and type, as well as grouping. For example, clustered, linear, and distribution, localized or generalized. Inspect the character of any exudates. Document color, odor, volume, and consistency. For example, thin and watery, thick and oily. Gently palpate any lesion to determine mobility, contour, flat, raised or depressed, and consistency, soft or hard. Document whether the child indicates tenderness during palpation. Measure the size of the lesion, height, length, width, and depth. Remove gloves and perform hand hygiene. For a child with an IV, don clean gloves and inspect and palpate the site for evidence of inflammation or infiltration. Remove gloves and perform hand hygiene. Assess the child's affect and mood, observing whether the child's expressions are developmentally appropriate. Match verbal and nonverbal behavior and determine whether behavior is appropriate to the situation. Observe the child for signs of abuse. Handle the interview discreetly. An interview about suspected maltreatment should be conducted only once by an experienced interview team of interdisciplinary professionals. If there is a specific injury, and if developmentally appropriate, ask the child how it happened. Record the child's exact words, as well as the family's account of the injury. Observe the child's interaction with the family. Be alert for indications of fear or a flat affect. Observe the family for hesitancy to report what happened to cause the injury, changes in details or implausibility of events, or unwillingness to give up control of the assessment. Note family members that have a history of violence, alcoholism, or drug abuse. Note whether the child has any obvious physical injuries or signs of neglect or malnutrition. Blood on underclothing, pain in the genital area, difficulty sitting or walking. Injury or trauma inconsistent with the reported cause. Injuries to the torso, eyes, or neck in a child younger than 4 years. 10-4 pneumonic. Look for contusions, burns, or abrasions with a pattern or shape. For example, bruises from a belt buckle or electrical cord, or burns from an iron or cigarette.